Let me start with the first person, Dr. Rajaree Giri. I'm told that you have 15 minutes for presentation.
Yes, sir.
And 5 minutes for discussion.
Yes, sir. Kajaree, sir. Very good afternoon to my respected seniors and dear colleagues. At the outset, I would like to thank the organizing committee and the scientific committee for giving me this opportunity to present my study, which is Spectrum and Clinico-Pathological Correlation of Renal Diseases in HIV in the HAART era. Do we need to screen all? A prospective study from a tertiary care center in South India. Coming towards the burden of HIV globally, around 38.4 million people globally were living with HIV in 21. 1.5 million people became newly infected with HIV in 2021. Among them, 28.7 million were accessing antiretroviral therapy. Coming to the burden of HIV in India there is a low prevalence rate of 0.3%. Still, it has the fourth most populous people living with HIV after South Africa, Nigeria, and Mozambique. In Telangana and Andhra Pradesh, we see that there is a higher adult HIV prevalence compared to the national standards. Hence, renal dysfunction in HIV is common. Poor viral suppression, ART toxicity, old age, and since the advent of HAART, people of HIV are living more, so they are more exposed to other chronic conditions like diabetes, hypertension, infections like hepatitis B and C, which precipitate to renal dysfunction. The burden is variable. It is 7 to 30% in India. The UNAIDS government has adopted this fast-track strategy to end the AIDS epidemic by 2030. It is about 95-95-95 strategy, but of which in India we see that around 77% only knows their HIV status. Of them, only 65% are receiving ART, and of them only 55% have viral load suppression. So the aims of this study was to screen for renal disease in people living with HIV on HAART therapy, to study the clinico-histological correlation of renal diseases, and the objectives were to identify the risk factors predictive of renal dysfunction and to assess the impact of early diagnosis of renal diseases on the clinical course. It was a hospital-based, investigator-initiated prospective longitudinal study. The duration was from January to October 2022, and patients having minimum follow-up monthly for 3 consecutive months were included. It was approved by the ethics committee. The study site was Osmania Medical College, which is a 5,500 bedded college and hospital. It is one of the oldest government medical colleges in India with the largest tertiary heart center in Hyderabad under NACO. Caters around 3,000 patients monthly, and it has facility of both IP as well as OP admissions. Till now, we used to get very few nephrology referrals to our nephrology department, and most of the patients used to be in ESRD, where we have limited treatment options. So this study was thought of in order to screen them early. The criteria were HIV positive patients aged more than 18 years, at least for 3 months taking ART, and with more than 95% adherence status. The exclusion criteria were pregnancy, diagnosed case of CKD due to other causes, active UTI, patients less than 18 years old, and unwilling to give consent. Coming to the materials, all HIV patients attending the ART center, inpatient as well as outpatient, are screened. Written informed consent form was taken. They were screened for spot proteinuria and serum creatinine. Confounding factors of proteinuria like uncontrolled blood sugar, hypertension, heart failure, they were excluded. Patient aged more than 18 years with serum creatinine of more than 1.3 or more than 1 plus proteinuria were included, and they again underwent a 24-hour urine protein estimation and repeat creatinine estimation to negate any laboratory errors. They were then classified into clinical renal syndromes as AKI or CKD, RPRF, and a nephrotic syndrome or acute nephritis, asymptomatic urine abnormalities like patients having only microscopic hematuria or proteinuria more than 1 plus, glycosuria with normal blood glucose, and electrolyte abnormalities. Detailed data was collected on a preform questionnaire. This was the ART that has been commonly used at our center, TDF, tenofovir, lamivudine, and dolutegravir, TLD. The few patients underwent renal biopsy, and the indications were nephrotic range proteinuria, presence of microscopic hematuria or combined hematuria proteinuria, nephrotic nephritic presentation, RPRA presentation, and unexplained AKI more than 2 weeks duration. Hence, the algorithm goes like this. Adult patients selected for screening was 1600, of which 966 patients met the criteria and underwent spot protein and serum creatine estimation. Patients having proteinuria more than 1 plus or creatine more than 1.3 were 332 patients. They again underwent repeat 24-hour urine protein estimation and serum creatinine. Patients having total proteinuria more than 150 mg per day or creatine more than 1.3 were 293, of which 12 patients withdrew their consent and 19 patients were lost to follow-up. So patient completed study duration was 262. Of them, 74 patients underwent renal biopsy. All this data were entered into the Excel and entered in SPSS 20. A p-value of less than 0.05 was considered significant. Hence, coming to the results, we see that the majority of the patients in this study were males with a secondary education level of 43.5%. Most of them was married. Mean age was 46 years. Most of them were occupied in 65.2%, and HIV positivity of partners were present in 27.4%. Most of them were living in the urban or peri-urban region. The mean CD4 count was 618 cells and mean viral load was 7,332, and it has a good virological suppression of 67.2% at this center. Most of the patients were in WHO clinical stage 1 and few of them required cotrimoxazole, and average time duration since initiation of HAART and screening was around 6 years. Coming to the co-infections, most of them had also had tuberculosis. Active tuberculosis was present in 8 patients, 5 pulmonary and 3 extrapulmonary, and they were all taking ATT along with ART. Coming to the therapy use, 78.2% of the patient had tenofovir-based ART regimen, and the recommended choice of first line of regimen now is TLD, that is tenofovir 300 mg, lamivudine 300 mg, and dolutegravir 50 mg as a fixed dose combination in a single pill once a day. Coming to the renal parameters, 31.2% of the patients are hypertensive, 19.8% of the patients were diabetic, and mean serum creatinine was around 3.36. Mean eGFR was around 57.5 ml per minute by 1.73 meters square. Coming to the eGFR cutoff, we see that the majority of the patient, 33.9%, were in CKD stage 3, followed by around 25% of the patient in CKD stage 2. However, a significant 19% of the patient was also in CKD stage 4. Coming to the complete urine examination finding, we see that the majority, 40% of the patients had proteinuria more than 1 plus, followed by 31% of patients having combined microscopic hematuria as well as proteinuria, followed by 14% of patients having microscopic hematuria, and nephrotic range proteinuria was also seen around 8% of patients. The majority of the patients had UPCR between 0.2 to 2 and serum creatinine between 1.3 to 3 mg per deciliter. Now, coming to the renal syndromes, we see that the majority of the patients presented as AKI, that is 27% of patients. However, we see a significant around 20% of patients also presented as asymptomatic urine abnormalities. When we further classified this patient, we saw 48.2% of the patients had microscopic hematuria alone, and 44.2% of the patients had both proteinuria 1 to 3, and 7.6% of patients had nephrotic range proteinuria, though they were clinically asymptomatic. And also renal syndrome, acute nephritic syndrome was also present in 16.4% of the patient, nephrotic syndrome in 8.3%, and RPRF in 13.3% of patients. Hence, if we combine all this data, we see all the patients screened, patients having renal dysfunction was 27.2%. Coming to the electrolyte abnormalities, we find the most common electrolyte abnormalities was hypocalcemia, that is 10.6%, which was mostly seen in patients shifting from acute medical care settings which require renal replacement therapy. Glycosuria in absence of hyperglycemia was also seen in 2.2, that is 6 patients. Coming to the USG findings, the majority of the patients had normal sized kidneys. However, 29% of patients also showed evidence of uretary calculi, and 13.2% of the patients and also had presence of bilateral contracted kidneys. Coming to the renal histopathology data, we see that the majority of the patients, around 21.6, had chronic tubulointerstitial nephritis, followed by ATI in 14.8, diabetic nephropathy in 13.5, and surprisingly, we got TMA in 9.4% of the patients. Other podocytopathies like FSGS and MCD was also seen in 5.4% each, and immune complex diseases like IgN, IgA nephropathy, MPGN was also seen in 5.4%. Coming to combinedly, the light microscopic finding shows that the glomerular involvement was predominant with 43.2%, followed by tubular involvement. However, glomerular and tubular involvement was also present in 9.4%. So this is a photomicrograph of the kidney biopsy sample showing interstitial inflammation and tubulitis compatible CTIN, and also this picture shows intense mesangial hypercellularity as well as interstitial inflammation, and immunofluorescence confirms IgA nephropathy. Now, when we correlated this histopathology data with the clinical renal syndrome, surprisingly we found that among 50% patients of CTIN, around 54.5% patients of ATN, 30% patients of diabetic nephropathy, and around 57% patients of TMA had asymptomatic urine abnormalities. Like these patients also had significant burden of renal diseases, so we should look out for them. The factors predictive of renal dysfunction and of HIV reveal that age more than 60 years, presence of viral load more than 1000 copies per ml, and the presence of diabetes has increased odds ratio, that is increased risk predisposing to renal dysfunction. All these patients were advised for strict follow-up at our outpatient department, especially the biopsy-proven case, and the mean follow-up duration was around 10 weeks. And patients of CKD grade 4 and 5 were advised for conservative management and antihypertensives, ACEI, statins, anemia, bicarb correction. Patients of HIVIC, all patients of MPG and FSGS MCD were started on low-dose steroids after ruling out all active infections and ACEI along with HAART. All cases of MCD and 2 patients of MPGN had more than 50% reduction in proteinuria. All cases of IRGN had remission. However, response in FSGS was variable. 1 patient lands in partial remission and 1 patient, however, had improvement in GFR. However, patients of crescentic GN continued to be dialysis dependent even after 8 weeks of therapy. Hence, coming to my discussion, we see that this present study has screened around 1600 patients, and this screening strategy was not done in studies abroad because this at that time HAART was not used for all patients. However, one study from North India, AIMS, they had screened around 290 patients, and number of patients included in this study was around 262. The prevalence of renal dysfunction in this study was 27.2% with microscopic hematuria in 15.6 and proteinuria in 23%, which was comparable to other studies. Coming to the discussion in the biopsy reports, we found one surprisingly increased presentation of TMA, 9.6%, which was not found in any other studies, though we found glomerular involvement in 43.2% and one FSGS NOA subtype. FSGS HIVAN was not found in any patients, and this can be explained by the fact that FSGS NOS is said to be one attenuated form of HIVAN after the advent of the HAART. So we again thought that what may be the cause of this increased presence of TMA? Is it causal or is it incidental? So literature review shows that TMA can be an initial presenting symptom of HIV infection, as my preceding speaker also told that it is a pattern of injury, and any patient of new onset thrombocytopenia and microangiopathic hemolytic anemia should be looked out for and should have a differential diagnosis. Also, we compared the biopsy reports of our same center in the same study duration patients, which was done in non-HIV patients. And we found TMA in non-HIV biopsies only 2%, whereas TMA in this HIV patients stand out to be 9.6%. So we also compared this study to a similar study done from our same center, Osmania, 10 years back, where 63 patients were referred to the nephrology department from ART center, underwent evaluation. 27 patients underwent renal biopsy, and most common histology was acute tubular interstitial nephritis. However, screening strategy was not adopted at that time because HAART was not for all at that time. However, now we had screened all patients because we have a new rule of HAART for all patients. And most common syndrome was AKI in both. However, in this study, 20% of patients still has asymptomatic urine abnormalities. Coming to the biopsy, as we told, we found a significant, the most common was CIN. However, TMA was also significant in 9.6% of the patients. So initially we went to a patient-centric approach, but now we went to more to a community-based approach where we as a nephrologist went to the ART center and screened all patients. So what this study adds, this study screens all HIV positive patients predominantly in an ambulatory setting where majority were outpatients. Renal biopsy has been done in a substantial proportion of HIV positive patients, probably the most in India till now, and all varieties of glomerular and tubular interstitial lesions can occur on histology. A significant proportion of patients have asymptomatic urine abnormalities, that is 20%, and renal histology even in those have revealed FSGS, MPGN as well as TMA. Asymptomatic HIV infected patients have significant burden of renal disease, and absence of HIVAN in proteinuric HIV patients is characteristic. So the question stands, do we need to screen all? And yes, we need to screen all these patients because ISN has also included HIV as a high-risk group, and the NACO current guidelines 2021 has also included urine microscopic and routine examination as part of routine screening. Previously, only creatinine was there as a part of screening or before initiation of ART. The strength of the studies was it was a screening study with inclusion of all patients irrespective of symptoms, first of its kind. The limitations were albumin-creatinine ratio was not seen. Electron microscopy could not be done in all because which could have picked up more heavy cases. APOL1 genotyping was not done. Hence, to conclude, asymptomatic HIV-infected patients have significant burden of disease. HIV is a high-risk group, so proteinuria and elevated serum creatinine can be an early marker of HIV-associated renal disease. Renal biopsy is crucial for correct diagnosis and management. Age, diabetes, and viral load more than 1,000 are independent predictors of renal copies. Since now we are more focusing on preventive nephrology, we believe that not only in Andhra Pradesh and Telangana, if we screen this population across India, we can save more patients landing to CKD and save more nephrons and kidneys. Thank you. These are my references. These are my acknowledge. I acknowledge my patients department and my guide, Dr. Manisha Sahai. Thank you.
Thank you, Dr.
Thank you.
Kajaree Giri.
Thank you, Dr. Kajaree. A couple of questions from the judges. Let me start. Did you have an idea of those patients who had massive proteinuria, nephrotic range proteinuria? What was the histology?
Sir, in massive proteinuria, it was around 8% of the patients had, and we mainly found MCD in them, sir. However, one patient also got FSGS.
Only one had FSGS.
Got elevated.
Right. Okay. You did mention hypocalcemia in over 10% yes, and few with the uretary calculi.
Yes, sir.
Is there any relationship with either the disease or the treatment?
Yes, sir. Actually, hypocalcemia mostly we found in patients which we took from the medicine department and who were ill and which required renal replacement therapy. So it may be a part of spectrum of AKI. And hypocalcemia we found, sir. And AKI in uretary calculi, we mostly I think it is a incidental finding because ART drugs, most of them is on TDF. But literature shows that actual TDF toxicity is not that common, sir. It is around only 0.3 to 1%. Because the characteristic histologic finding of TDF toxicity are not seen in any of the biopsy reports.
Okay, thank you.
Thank you. Thank you for your presentation. Just want to say the answers in just one sentence. What is the importance of your study?
Sir, the importance of my study is that we should take all HIV patients as a high-risk group. And we should screen all HIV patients because in this study we find many asymptomatic HIV patients also have significant renal disease. So by doing this, we can save more patients before they land up in CKD. Because
I want only one sentence. Your point is now that in addition to treating high-risk group, you also want to get the low-risk group also treated. To
yes,
prevent
sir.
renal disease. Is that what you mean?
All patients have HIV, sir. Yeah.
Okay.
Both high risk, low risk.
Right,
all patients are high risk.
Only one sentence. Next question for you is, what is your involvement in the study? What have you done in the study?
Sir, initially when we thought of this study, sir, it was a small pilot project. I used to go to the ART center, sir. There I saw that they were not doing complete urine examination as a routine. They were only testing creatinine. So we told them to do complete urine examination. Initially they were a bit hesitant. So I used to give CUE slips for them and collected the reports. No. And all the patient having abnormalities to come to me then. No. And we did biopsy.
We wanted you to answer in only one sentence. Okay. The last question for you from my side is, what is your conclusion in one sentence? We don't want a series of long sentences, just one sentence. What is the conclusion of your study?
The conclusion of this study is asymptomatic HIV patients also have a significant burden of renal disease.
No.
That's okay, fine.
Just that conclusion.
Yes, sir.
Based on what? You did not compare that to anybody else. So without comparison, how can you make that conclusion?
Comparison between...
Let us say you have some other clinic, non-HIV clinic. If you had compared that to HIV patients and you, in fact, I don't know, do we need to screen all when you said in the title?
Yes,
what exactly you mean by screening?
Yes, sir. There is one point, like normal patients who have no symptoms, we don't do complete urine examination of all.
My question is, when you say, do we need to screen all, screen all for what? Creatinine and urine?
Urine examination, correct. Yes, sir.
So, unless you tell me that your medical clinic non-HIV patients had less renal disease versus HIV patients had more renal disease, you cannot make such conclusion.
Okay, sir.
That's what I wanted to convey. So because there was no comparison. Basically,
Okay.
I would have suggested correlation of renal disease in patients with HIV in the HAART era is fine.
Okay,
But
sir.
the next one is not supported by your conclusion.
Yes.
Okay, thank you. Thank you for your presentation.